Hi, my name is Kamel Abou Hussein. I am from the Department of Hematology and Medical Oncology at Cooper University Hospital. I was asked to give an overview of the management and goals of care for metastatic breast cancer for primary care physicians and NPs. Those are my disclosures. Miss M is a 56-year-old female who was recently diagnosed with metastatic breast cancer involving her liver and bones. She had a liver biopsy showing involvement with grade 2 invasive ductal carcinoma, which was ER positive 90%, PR positive 80%, and HER2 negative. She was started on a combination of letrozole and palbociclib with overall good tolerance. Upon progression, what mutation would qualify the patient for treatment with alpelisib and fulvestrant? 1. PD-L1, 2. MSI high, 3. PIK3CA, 4. BRCA. The correct answer is PIK3CA, which is a mutation found in about 40% of patients with metastatic hormone receptor positive breast cancer. Objectives of my talk will focus mainly on goals of treatment and the predictors of response, and how do we get to choose what type of systemic therapy, and then we'll touch quickly on some of the new therapeutics in the different subtypes of metastatic breast cancer. Now, although metastatic breast cancer is unlikely to be cured, meaningful improvements in survival have been seen, and that coincided with the introduction of newer systemic therapies. The median overall survival for the different subtypes of the metastatic breast cancer collectively is now slightly over 3 years. But of course, there is a wide range from a few months to many years based mainly on the subtype of the cancer that we're looking at, the sites of metastatic disease, the burden of the metastatic disease, and we see a very good number of patients who experience long-term survival. The selection of the therapeutic strategy depends upon both the tumor biology and the clinical factors, with the goal of developing a tailored approach to each patient. Now, although a subset of patients with oligometastatic disease may benefit from an intensified form of local regional approach, but the main cornerstone of your treatment will always consist of systemic therapy, whether it is chemotherapy, endocrine therapy, biologic, or immunotherapy, along with some form of supportive care measures. But really, the primary goals of our treatment would be to mainly prolong survival, alleviate the symptoms, and maintain a good quality of life, while providing patients with treatments that have their own toxicities. This is a representation of the different subtypes of breast cancer. So you can always remember that the most common subtype of breast cancer, of course, is the hormone receptor positive. So here you see the ERPR positive subset, which is about 3/4 of the cases. And then to a lesser extent, we have the HER2 positive and the triple negative disease. Now, touching on some of the predictors of response. So the most important thing that drives the treatment is the hormone status and the status of the HER2 overexpression. Along with that, patients who are carriers for genetic alterations in BRCA1 and BRCA2 are more likely to respond to PARP inhibitors. And when we are looking at the response predictors, so consistent predictors of poor response are a patient who has quick progression after starting prior chemotherapy, or a patient who has relapsed 12 months after completing adjuvant chemotherapy, or someone with a very poor performance status or multiple disease sites, especially if there is visceral involvement. We also look at some of the parameters like the proliferation index, the Ki-67, which is usually associated with a higher chemotherapy response rate. Now, the question comes about whether we should use single agent chemotherapy versus combination. In general, really, single agent chemotherapy used in sequence is preferable to combination chemotherapy, since the single agent chemotherapy is reasonably likely to induce palliation with a fewer number of side effects. And we don't have any studies that have documented that there is an improvement in overall survival with the use of the combination chemotherapy, as long as both of the drugs are available to be used in sequence. Now, having said that, it is reasonable to consider using combination chemotherapy in the right context. So somebody who has a large tumor burden or visceral crisis, or when you are in a rush to get a quick response to prevent impending organ dysfunction. The first subset of metastatic breast cancer that I would like to focus on is the hormone receptor positive breast cancer. Now, it's really important to know that for years and years, we have been targeting the estrogen pathway to decrease the drive for the replication of the cancer cells. So we've been using a lot of anti-estrogen therapy, including things like tamoxifen, aromatase inhibitors, and fulvestrant. But knowing that the estrogen receptor makes a protein called cyclin D, which binds to the cyclin D kinase 4 and 6 subunits. And this combination really leads to driving the cell cycle to replicate. So when you block the estrogen receptor and you inhibit the CDK4/6 complex, you significantly decrease the estrogen drive for the growth of the cell cycle for breast cancers. So we do have different agents available in the market, namely 3 different agents. Those are the palbociclib, abemaciclib, and ribociclib. And those all initially were approved after initial trials that combined them with an aromatase inhibitor. So here we're looking at 3 different trials: the Paloma 2, which studied palbociclib, Mona Lisa 2, which studied ribociclib, and Monarch 3, which studied abemaciclib. And in all of those trials, you do see an improvement in progression-free survival with a range of about 9 to 10 months, almost doubling of the progression-free survival, with a nice hazard ratio that was around 0.5. So that led to the initial FDA approval in combination with an AI. And then after that, we had other studies that combined them with fulvestrant, and we were able to see the same exact benefit. And we also are starting to see some overall survival benefit. And just some examples of that is the Mona Lisa 3 trial that combined ribociclib with fulvestrant and compared it to fulvestrant alone, where we've seen an overall survival in the postmenopausal setting. Here, you can see the nice separation of the curves with a hazard ratio of 0.72. And we've also seen the same results when used in the premenopausal setting in the Mona Lisa 7 trial, where they treated the premenopausal women with ribociclib along with endocrine therapy compared to endocrine therapy alone. And again, we've seen the same improvement in survival. And for the abemaciclib, there was the Monarch 2 study that showed an overall survival benefit when the abemaciclib was combined with fulvestrant compared to fulvestrant alone. And that held true even for patients with poor prognostic factors, like patients who had primary endocrine resistance and patients who had visceral metastases. Looking at the side effects to be expected from all of those agents, the most common side effect really is neutropenia. Neutropenia happens in the majority of patients. What is good about it is in the trials, we've seen that even though the neutropenia almost impacted almost every patient, we've seen that less than 1% of those patients ended up with febrile neutropenia. So it's not clinically concerning. It is also different than the neutropenia that you develop from chemotherapy, as this is a transient arrest in the cell cycle, while in chemotherapy, there is killing of the progenitor cells, so it takes a longer time with chemotherapy to recover, while here it recovers quickly. The second most common side effect are GI side effects, mostly the diarrhea, and especially linked to the use of the abemaciclib. And the management guidelines, if they are followed strictly from the beginning, it could be very successfully managed. There are less common side effects, including venous thromboembolism and fear for prolongation of the QT interval, along with interstitial lung disease and renal impairment. Then we had another trial, the SOLAR-1 trial, which looked at metastatic hormone receptor positive breast cancer patients. And it tested the combination of alpelisib, which is a PIK3CA inhibitor, along with fulvestrant compared to fulvestrant alone. And they broke down patients based on the mutation status. So it was 1-to-1 distribution of whether the patients harbored the mutation or not. And they did show that there was an improvement in progression-free survival. It went up from 5.7 months to 11 months with the addition of alpelisib to fulvestrant with a hazard ratio of 0.65 in the mutant population. The side effects for this medicine is a very high incidence of high-grade hyperglycemia that needs very close monitoring along with skin rash. Now, shifting gears to talk about a different subset of metastatic breast cancer, the triple-negative breast cancer. I think we have learned over the course of the last few years that the relationship between the immune system and breast cancer is a dynamic process where when the breast cancer is initially exposed to chemotherapy and there is killing of the cancer cells and presentation of the new antigen to the immune system and priming and activation of the immune system and trafficking of the T cells that end up going to the tumor and starts infiltrating the tumor. And then the immune cells start recognizing the cancer cells as foreign, and that ends up in killing of the cancer cells. The study that was practice changing was the Impassion 130 trial. And this is a trial for the first-line metastatic triple-negative population where they randomized patients 1-to-1 to either using the nab-paclitaxel alone or nab-paclitaxel along with an anti-PD-L1, the atezolizumab. And the co-primary endpoints for the trial were progression-free survival and overall survival, both in the intention to treat population and in the PD-L1 positive population. This trial used an assay for PD-L1 testing called the SB142, and about 40% of the patient population on the trial tested positive for the PD-L1, and the definition of that was anything higher than 1% PD-L1 staining on the tumor infiltrating immune cells. And here are the results. When they looked at the progression-free survival, you can see that there was a slight improvement in the PD-L1 positive population compared to the intention to treat population. But once again, it was not an impressive improvement in progression-free survival. The real benefit of the trial was shown when they looked at overall survival. While they did not show any difference in overall survival in the intention to treat population, but in the PD-L1 positive population, there was a very impressive improvement. It went up from 19.7 months to 25 months, so about 7 months improvement in overall survival in the PD-L1 positive population. So that became the standard of care for first-line metastatic triple-negative breast cancer that is PD-L1 positive. And it's a regimen that is, for the most part, well-tolerated, with the most common side effects really are neuropathy, nausea, neutropenia, and immune-related side effects. Then there was the introduction of this exciting molecule in April of this year, sacituzumab govitecan, which is an antibody drug conjugate that is targeting the TROP2 receptor, which is heavily expressed on the surface of cancer cells. And that was linked to irinotecan. This was, the approval was based on a single-arm trial in heavily pretreated metastatic triple-negative breast cancer patients. It had more than 100 patients that were tested on that study, and there was more than 30% objective response. Now, talking about the metastatic HER2-positive breast cancer, the standard of care for first line is usually a combination of trastuzumab, pertuzumab, along with a taxane. And then second line, usually we would use an antibody drug conjugate with the TDM1 or the Kadcyla molecule. Now, we had introductions of several exciting molecules in the HER2 positive area. It's been a very, very good year actually for the HER2 positive metastatic breast cancer. The two that I would like to focus on are the trastuzumab deruxtecan and the tucatinib. Trastuzumab deruxtecan is an antibody drug conjugate that is linked to a topo-1 inhibitor. And the tucatinib is a selective small molecule tyrosine kinase inhibitor that does not bind to the EGFR receptor, so it has less EGFR-related toxicities compared to the other molecules, the TKIs like lapatinib and neratinib. So the first trial that I would like to talk about is Destiny-1 study, and this was a phase 2 study that looked at a population of metastatic HER2 positive breast cancer that have seen TDM1 before. And the initial part of the trial was to determine a safe dose for the trastuzumab deruxtecan, and they decided that it was the 5.4 milligram per meter square. And they did actually show more than 60% objective response rate with the use of this drug, which is quite an impressive number. The median progression-free survival on the trial was 16.4 months, and the median overall survival was not reached. Regarding the side effects, really the one that was most concerning is the grade 5 interstitial lung disease, where 4 patients on the trial unfortunately died. That led to the FDA approval of trastuzumab deruxtecan in December of 2019 for patients who have metastatic HER2 positive breast cancer who have received 2 or more prior anti-HER2 based therapies. Then the other exciting trial is the HER2 CLIMB trial. This trial studied a very similar population of metastatic HER2 positive breast cancer, and those patients have seen trastuzumab, pertuzumab, and TDM1 before. They broke them down into a 2-to-1 distribution of either capecitabine and trastuzumab alone, or capecitabine and trastuzumab along with tucatinib. And the dose of tucatinib was 300 milligrams PO BID. So this is an oral, well-tolerated TKI. The difference between this population and the population that was studied under the Destiny-1 trial is the population in the Destiny-1 trial, even though they allowed patients with treated and stable cranial metastases, so CNS metastases, this one included patients even who had progressive CNS metastases, which is really important. Here you can see the beautiful outcomes of the trial, where there was an improvement in the tucatinib curve, which is the light blue curve. There is an improvement in progression-free survival and in overall survival, and an improvement also in patients with active brain metastases. The most common adverse effects from the tucatinib are diarrhea, even though the majority of the diarrhea cases were low-grade diarrhea, and along with that, there's some hand-foot syndrome and some other GI side effects. That led to the FDA approval of the drug also in December of 2019 for patients with metastatic HER2 positive breast cancer, including the patients who had brain metastases who have been treated with trastuzumab, pertuzumab, and TDM1 previously. Now, just a couple of slides about our treatment for metastatic breast cancer patients during COVID-19. So the administration of chemotherapy during this time should be a decision between the patient and their doctors. So this is something that should be handled on a case-by-case basis. You should have careful considerations regarding what is the indication of giving therapy right now, what was their response to prior treatment, and the risks and the benefits of continued treatment. So for example, if you have a patient who's doing very well, had deep remission, and there is no rush to give them chemotherapy right now, and they would prefer to take a little break, you could consider stopping chemotherapy. When it comes to the immune checkpoint inhibitors, this is where we have some conflicting data because there are some concerns about the immune checkpoint inhibitor therapy exacerbating the clinical course of COVID-19 if your patient receives immune therapy and ends up with a COVID infection. Also concerns that COVID-19 may impact the ability to diagnose and treat the immune checkpoint-related side effects. One most important side effect here is pneumonitis, where the symptoms of COVID-19 infection and the symptom of the checkpoint inhibitor-related pneumonitis are going to be similar. And the checkpoint-related pneumonitis is usually treated with glucocorticoids, which is something that is cautioned against if you are treating a mild to moderate cases of COVID-19. So for any individual who has had exposure or diagnosis of COVID-19, I think it would be wise to hold treatment until there is further clarification of the clinical picture and the patient is felt to be more stable. I hope this has been helpful in clarifying some thoughts about the general philosophy and goals of care for management of metastatic breast cancer. And thank you.